Shall I start?
Islam, you can start presentation.
Okay. Good afternoon. My name is Islam Balboula. I am one of the anesthetic registrars in Northwick Park Hospital. And today we are going to discuss one of the common respiratory problems in the ITU, which is the acute respiratory distress syndrome, or ARDS. We will start with definition of ARDS. The first accepted definition was presented to the world in 1994, which is the American European Consensus Conference definition, and was updated later in 2012, which is the Berlin definition. There is actually minor differences between both of them. Both definitions describe ARDS as acute onset of acute respiratory failure with bilateral opacities in chest X-ray or CT. Both definitions rolled out a cardiac cause of the problem, but in different ways. In the old definition, we have to measure the pulmonary artery wedge pressure to be below 18, which is actually not practical that much. As it's not usual to insert Swan-Ganz catheter to every ARDS patient. Now it's more simple, more realistic. We can just do echo and exclude left ventricular problem. The last point is the classification. In the old definition, it was classified to acute lung injury if the PF ratio between 200 and 300, and acute respiratory ARDS if PF ratio is below 200. In the new definition, they omitted the acute lung injury term completely, and if PF ratio below 300, it's ARDS, and we can classify further to mild if PF ratio between 200 and 300, moderate from 1 to 200, and severe if PF ratio below 100. As you see, there is minor differences. In Berlin definitions, it speaks about clear onset, 7 days with 7 days of a known risk factor. It wasn't defined before in the previous definition. And we can exclude the cardiac cause of the problem, but it's not necessary to measure the pulmonary artery wedge pressure as before. And also the classification. We have but also we have to apply some PEEP at least 5 centimeter water to define it as ARDS. So simply, it's acute respiratory failure with bilateral opacities, which is not cardiogenic in origin. How does this happen? On the left side of the screen, you can see this is the alveoli outlined by alveolar cell type 1 and type 2 alveolar cells. This is the interstitial space, and this is the blood vessel outlined by endothelium. What happened? This is the blood alveolar barrier. What happened simply is inflammatory damage that bridges this barrier with flooding of protein-rich plasma into the interstitial space and into the alveolar space. This is mediated by damage mediated by multiple types of inflammatory cells and cytokines, especially interleukin 8. And this stage is called exudative stage. And this fluid inside the interstitial space and the alveoli, and the alveolar space is full of protein, various type of inflammatory cells, platelets, RBCs, and as you see, there is microvascular thrombi as a part of the pathogenesis as well. Later on, the sequelae would be one of two scenarios. Either recovery scenario, which is the proliferative stage, or the fibrotic stage. In the proliferative stage, all type of cells proliferate again. As you see, the alveolar cell recovered again and started to secrete surfactant, and they are trying to pump the excess fluid through the lymphatics. So there is ongoing recovery for the endothelium, for the blood vessels, for the alveolar wall, the alveoli itself. So in some patient, for some reason, what happened in fibrotic stage, there's fibroblast and myofibroblast predominate and cause fibrosis everywhere in the alveoli, lymphatics, blood vessels, interstitium. So we lose the lung literally. So 3 stages: exudative stage, and proliferative stage in terms of recovery, and fibrotic stage in terms of complication. For the causes or differential diagnosis of ARDS, there is direct. We can classify it to direct and indirect causes along the list, but on top of the list is pneumonia and non-pulmonary sepsis. It can also happen with after aspiration of gastric content, lung contusion, fat embolism, near drowning, inhalational injury, multiple trauma, massive transfusion, acute pancreatitis, massive burn, and with cardiopulmonary bypass. And this the symptoms should start within 7 days of a known risk factor or an insult. So the patient will be presenting with deteriorating respiratory status. You can expect shortness of breath, dyspnea, tachypnea, hypoxemia, cyanosis, pallor, crackles initially in the bases of the lung, then profound. All of that will be taking place shortly after the initial insult. Again, few hours to 7 days of the insult. So from the history taking, we hopefully have an idea about the underlying cause. Also, we can try to identify if there is any heart failure or potential cardiogenic pulmonary edema. It can also, if a patient having cardiogenic pulmonary edema, that can not exclude ARDS completely. It's possible to have a component of both. Regarding the investigation, one useful tool is the chest X-ray. According to the Berlin definition, we should have bilateral opacities in both lung fields. CT scan, it's not typically performed for diagnosis, but it can differentiate other causes of ARDS, other causes of that condition. It can also, we can include abdomen and pelvis in the scan in order to diagnose any source of sepsis or infection. It can also help to identify heart failure or cardiogenic pulmonary edema. Also, echo to exclude the cardiogenic pulmonary edema, and some labs like EBG, BMP, nasopharyngeal PCR, blood and sputum cultures, CBC, CIP, procalcitonin. Management, usually it's ABCD, airway, breathing, which is a specific treatment as well in this for this condition, and circulation, disability, and CNS. For the mild cases, it can be managed with non-invasive ventilation or high flow nasal, while moderate and severe cases require mostly they will require endotracheal intubation with mechanical ventilation. Our goal in of mechanical ventilation is to achieve adequate oxygenation and ventilation, not necessarily perfect. So PO2 of more than 80, more than 8 is accepted. BCO2 less than 8, permissive hypercapnia, provided that the pH is more than 7.25, and saturation of more than 88, and plateau pressure less than 30, and the driving pressure, which is the difference between the plateau pressure and the PEEP, shouldn't exceed 15. The idea is that we can give, if we give too large volume to achieve saturation of 94, it's better and it's more safe to the patient to achieve saturation of 90 with plateau pressure less than 30. This is the lung protective ventilation. We should use low tidal volume ventilation, 4 to 6 mils per kg of the ideal body weight. We should calculate the ideal body weight for that. That's the equation for the male and female. We should target plateau pressure below 30 and the driving pressure less than 15. And regarding the PEEP and the recruitment maneuver, we will discuss in the next slides. So again, if we are giving too high PEEP to such inflamed and atelectic lung, we can cause biotrauma. If we are giving too low PEEP, especially with the surfactant, with a low level of surfactant, we can achieve, we can cause the lung to collapse and cause further damage to it. So how to optimize the ideal PEEP, there is two ways for that. This is the pressure volume loop we can find on the ventilator. The pressure volume loop, this represents the inspiration, and this is the expiration. On this part of the curve, when we apply, when we increase the pressure, there's not too much increase in the volume, and here and suddenly there's dramatically increase in volume with increasing the pressure. We call this point upper inflection point. And then at this point, again, with increasing the pressure, we are not achieving much increase in volume. So simply our ideal PEEP should be between above, between the lower and upper inflection point. To perform that, we need the patient to be paralyzed with no straining, no coughing. So it's not practical in every patient. So simply we can have the other way with increasing the oxygen requirement. We can find an increase. We can increase with the increasing FiO2. We can increase the PEEP according to this table. So recruitment maneuvers. In recruitment maneuvers, we aim to increase the transpulmonary pressure, transient increase in transpulmonary pressure to allow recruitment of collapsed alveoli. This shouldn't be performed in every ARDS patient. This is not a routine practice. And there's several ways to achieve that. The most famous is the sustained inflation. As you see, this is the normal breath. Then we can apply CPAP or pressure of 40 for about 40 seconds. But we should monitor the patient. We should paralyze the patient before the trial, and we should carefully monitor monitor the patient for that, because he may develop hypotension or arrhythmia during that. Another method called psi breath. This is the normal breath, and every 30 seconds we can put one psi breath, which is higher in volume or higher in pressure according to the mode we are using. We can apply 3 consecutive psi breaths every 30 seconds or every 1 minute, whatever you like. It looks like intermittent recruitment, not just single trial for 40 seconds like the one before. Another way we call the extended psi. So we apply, you can see this is the PEEP level, and this is the peak airway pressure. So this we can increase the PEEP incrementally every 2 minutes, keeping the driving pressure the same of 15, for example, and continue escalating. For example, we can increase the PEEP from 15, then 20, 30, up to 40 or 45. Then we can go down slowly. So we can give the recruitment maneuver over a longer period of time. It needs some time to be done, and it's more physiological than the previous one, or the sustained inflation. So whatever the method for recruitment, studies failed to prove that recruitment maneuvers make any difference in terms of mortality. It might improve oxygenation, but only for a few hours. Then EPG deteriorates again with no impact on mortality. Now we come to the broom positioning. Broom positioning help redistribution of consolidation from dorsal to ventral areas of the lung. This is the lung in the supine position, and this is in the broom position. As we know, the pathology predominate dorsally, and the ventral part are less affected. So when we broom the patient, we get more blood supply to the ventral part, increasing and improving the matching between ventilation and perfusion, and also the cardiac weight. The cardiac weight is now down. It's not over the lung now. As you see, also so this helps us to improve the alveolar ventilation, the shunt reduction with increased oxygenation. We should consider pruning if the PF ratio is less than 150, and it should be done for 16 hours a day, and it was associated with reduced 28 days mortality compared with supine ventilation. Neuromuscular blockage. It should be early considered in severe cases with BF ratio less than 150. The drug of choice is cis-atracurium, can use up to 48 hours. And this will improve the synchrony with ventilator and reduce the oxygen consumption and improving respiratory mechanics. Regarding the fluid management, we should keep the balance, the net balance or negative balance if tolerated, but not positive balance. It was found to increase oxygenation and was associated with more ventilator-free and ICU-free days. Generally in the ITU, patients should be lightly sedated, emphasis on analgesia. Benzodiazepines should be avoided when possible. They found also that early deep sedation in mechanically ventilated patient associated with increased mortality. And also early mobilization was associated with improved outcome in patient with acute respiratory failure. Corticosteroid, the idea behind corticosteroid, as we know from the pathophysiology, it's an inflammatory process. So the idea of giving corticosteroids is to stop this inflammatory process, but it shouldn't be used routinely in every ARDS patient. There's inadequate evidence to make a definitive recommendation in favor or against the use of corticosteroids in ARDS. And it was found to be harmful if started more than 14 days after the onset of the syndrome. But in some patients, like COVID patient, we should start. So it should depend on the cause, and the patient should be assessed by the ITU team for that. It's not improving the hospital mortality and not recommended for routine use. Now the inhaled nitric oxide. Nitric oxide is a pulmonary vasodilator, which can improve the VQ matching and improve the oxygenation. But it was not found to reduce the mortality in patients with ARDS. It can improve the oxygenation for a few hours, but it was associated with rebound pulmonary hypertension, and there is a risk of renal impairment, and it's not improving survival. Finally, we are going to talk about ECMO. ECMO is a technology that bypasses the lung and the heart, so that we can give the lung time to heal. We can rest the lung and stop damaging the lung further by the ventilator while the recovery takes place. We should consider if PF ratio still below 150 and the patient is not responding to optimum conventional therapy. Not everyone is candidate for ECMO, but we should evaluate the patient for it early. Consultant will decide if and when to refer to the ECMO team at Brompton Hospital. We should calculate the respiratory ECMO, the score. You can find online calculators for it. It include the age, if the patient is immunocompromised or not, and the treatment he had received. A lot of point, and you can calculate it online. And there is also ECMO referral checklist available on the intranet, and should be used for all referrals. So as a summary of the therapeutic options in management of ARDS, this is the intensity of the intervention, and this is the PF ratio. This is mild ARDS, moderate ARDS, severe ARDS. For mild cases, we can consider non-invasive ventilation, low or moderate PEEP, low tidal volume ventilation. For moderate cases, moderate and severe cases, we should consider higher PEEP, neuromuscular blockade, prone position, and ECMO. Thank you. Any questions?
I just had one question. What mode of ventilation should we be using for ARDS?
There's no single mode having benefit over other modes. We can use volume controlled modes, pressure controlled, inverted ratio ventilation modes. There's no evidence that one mode is superior to other modes.
Okay, thank you.
I also agree with Islam, Ahad. Reason is the purpose of your ventilation is to establish oxygenation
Yes.
and allow rest to the lungs so as to allow the own natural healing process. And
Yes.
like he has mentioned before, it can either change into a fibrotic lung or else the alveoli can recover rapidly by as if it were like the before.
Yes.
Okay. Any other doubts?
No, so essentially, can you use some kind of pressure regulated modes?
Yes, you can use.
Yes. And yes.
Uh,
Yes.
And I think, I don't know, Ahad, when you were there or no, that time Teddy had presented on APRV mode of ventilation.
Oh,
So
yes.
Yes.
that is
Is it
also
the,
mode.
I was just gonna say, I think I remember him mentioning P mask P ventilation equations.
Yes.
Yes.
And most
Thank you.
importantly, in that ventilation, that is APRV, you need a spontaneously breathing patient. Then only the mechanics will happen properly. Whereas in other modes of ventilation that we are using, because they are essentially positive pressure ventilation, you have to paralyze these patients. Otherwise, there will be interference between the uh, patient's mechanics as well as ventilator mechanic, and that can lead to baro or volute trauma. But mind you, when I'm saying paralysis, it doesn't mean you have to paralyze the muscle. You can use alternatives like keeping the patient deeply sedated as well. Okay. Any other doubts? So I think let's end our conversation here, and I'll circulate the feedback form for Islam in a few minutes from now. Okay. So thank you, everyone. Thank you for joining, and let's meet next week.
All right. Thank you.
Thank you.